So yes, I mean, if you're more a clinician, this might speak to you. So I'm Susan Birkhoff. So I'm the Director of Technology Research and Education, and I just presented a few weeks ago on MOX at Christiana. And this I'm going to present about the work that I did in my postdoc, University of Pittsburgh. So I'm not the traditional postdoc trainee that, like you go from your PhD and then go into a postdoc. So I did a pit stop for several years at Christiana as a neuroscientist, but, I was studying technology, but there wasn't really much like mentorship. It's hard, like specialized for technology and clinicians. And so I spoke to one of my former professors and she's like, you should really look into a postdoc, specializes in this, and University of Pittsburgh does. So I applied and I was accepted into their T32. And so this work that I did, my training finished at the December 31st of 2022. So it's not terribly old. And I'm going to talk through this early work that I did at Pittsburgh. Anyway, there we go. So I have no conflicts of interest, and I said, all right, this is Pittsburgh work. So when I was applying to Pittsburgh, like I already had a track record around virtual reality. So that's what Erin's talking about. So I've done some virtual reality work at the Helen Graham, and I also, not virtual reality work, but I've also done research work at Penn Medicine in their Roberts Proton Therapy Center as well. And just as a nurse too, like family caregivers, like there's a lot of information for patients, but not so much for those family caregivers. And I really noticed this gap around that. And so applying to Pittsburgh, of course, they want to know what's going to be your research idea. What are you going to be doing? And I really wanted to learn the early part of how do you create technology. And for me, it was going to be around virtual reality experiences, but I really wanted to understand, what does that look like? How do you conduct that kind of research? It's very different than research that I know how to do in the health system. And so I had the idea for, creating this experience specifically for these oncology family caregivers, because there's really not much out there to get them ready, them specifically for their needs before treatment commences. And so that, looking in the literature, I couldn't find any similar experiences that were published. They weren't out there. And so this kind of kicked off what I was going to do for my training. And so this was a framework that I used. I had a triple aim study, and I took a lot of classes around human-centered design interaction, UX engineering, and to really understand the technical piece behind it. And then, of course, I brought my clinical experience and expertise to it as well. So using this whole design thinking, and this is a fantastic framework, we're really understanding, like research, what is the problem? You need to define that problem. But then what's different is, how, well, I guess not really, because depending on what you're doing, how would you solve it? But then for here, creating a prototype and then testing it. And you have to, like, these early innovations, like you have to just keep testing them over and over and make sure you're actually hitting the mark. So it can be quite time intensive doing this work. So it took me, for my triple aim study, it took me 2 years. So I got it done, but yeah, it was a lot of work. It was no joke. So applying this design thinking framework. So just a high level overview, identifying that problem and studying the needs of the population that, I intended for them to be my end users. There is definitely a lot of literature out there around caregiving, like so much, but for me to go through that process, I wanted to conduct my own study as well. And then, based on that feedback, really sketching out that solution, which of course was going to be this virtual reality storytelling experience. But I did low fidelity, which I was, learning. And it's so important to not spend the time and effort to make something polished and perfect, that you actually kind of want it low fidelity, kind of gritty, kind of rough, and to get that early feedback. So then it's easier to change it, and it's, less time, less effort. And so then you are hitting the mark when you do then try to scale up and make something, much more polished, or moving into the high fidelity area. And then from there, I created a storytelling videos and then put it into a 3D experience. And then I put a study behind that as well. And I didn't have, like the really nice virtual reality goggles. I mean, it was a step up from that little girl in the picture. It wasn't quite Google Cardboard, but it was and enclose VR hardware, but then you would slip your own personal phone into that. And that's what we used. And so this was, this was the first aim of my study. As I said, there's a lot of information out there around caregiving, but I wanted to go through, this process to learn, and especially because it lives in the qualitative world, which I'm more of a quantitative researcher. So I spent my 2 years learning all about qualitative research, which I'm not really a fan, but you have to do it. But so for the first several bullet points, none of this is surprising that, this is scary. This is, you don't know what to expect. You're nervous about it. But what kind of resonated at the bottom one was really being unprepared to be that caregiver. A lot of the data that I was collecting was just like, what does that even mean? What does that even mean for me? Like, what do I need to do? How do I even prepare? And it was interesting too. I had a few men who were in this first part of the study, and getting their feedback was definitely different than the traditional, female who are traditionally the family, caregivers, and their needs seem to be different, especially with the caregiving. Like they really were like, I didn't know what to expect. So that is definitely an area ripe for research right there. But that was very interesting. And then also the other part of it too was, well, how can we, improve this pre-treatment education? And again, this is before they start treatment, like you're getting ready for it. Their loved one's going to get treatment. You're getting ready for it. And a lot of them, the feedback was around, like giving me a piece of paper or verbally telling me, maybe that works, but they wanted different ways to receive that education, having an explanation of what to expect, and also more emotional support. A lot of times they were told, well, you can join a support group. Okay. And, maybe like they're so busy, maybe it doesn't fit into their schedule, but they want that human connection. And then the other big thing that stuck out was they really wanted more touch points with their oncology team, because this is the pre-treatment time, and you really don't start having those touch points until your loved one starts receiving treatment. And so, they wanted a way to be like reassured. And, again, maybe there could be some kind of opportunity, not saying virtual reality, but opportunity there, so they could have those touch points, especially areas that they felt that they wanted to be reassured, which was around side effects or, what they need to do, like how are they going to care for this loved one. And so I guess I probably should have put a slide in for like the second part. The second part was me creating these experiences. So I developed personas. I had do storyboarding, and then like putting this whole script together. And then I recruited friends to be my actors, because this was a postdoc budget, so I did not have paid actors. I had friends that did the storytelling for me. And once I had that all together and put it into, because I put it on YouTube in a 3D experience that would go on their phone, and then they would put it into the headset. Then I had that one-to-one interviewing, and this was early user experience testing. So sometimes you might see UX, that's what it is. And so this was qualitative content analysis, and really, I spent a lot of time, creating these stories, having them vetted, and hoping that they're hitting the mark. But now it's time to really test it with caregivers and bringing them in. And I can say Pittsburgh has this really robust registry. It's called Pitt Plus Me, something that I think, I don't know if Delaware has anything like this, but ooh, it's fantastic. They have like 250,000 people where you can like put your research out there and people sign up for it. So it's a fantastic way to recruit. And so this is how I found my this sample for this part of the testing. And so when they watched all 4 different stories that I had, and so they found them to be relatable, which I was like, great, because I spent a lot of time, really working on these stories, based on the findings from the first part of the study, and then creating these stories. So I was pleased that they're relatable. And then also it was evoking emotional responses, but I also heard they were too emotional. Like some people wanted to cry, and I was like, I don't know if that's exactly what I was going for. And I was like, oh gosh, I'm going to make you feel worse. And so I'm like, I might really need to rethink that. So I'm glad having that early testing to get that feedback. And then also decreasing distractions. I mean, this was a lot of work to put something, something 3D, which you're like, well, could you kind of have the same effect if you just did 2D? And so I was asking questions around that, and they felt to really be immersed in that story 3D is the way to go, because if you're looking at your phone or looking at something else, you can just look around or do anything else. And so they felt it helped for that connection piece around the story. Younger generation felt it was easy to use, you know. And a lot of them talk about like gaming, and they're like, you know, this has to be on the level of like gaming. And I'm like, I know this is like early, low fidelity, but they felt it was easy to use, to get it on the phone and put it into the headset. But then there, on the flip side of that, is a generational use as well. So I had some, you know, older participants, and this one, she was a grandma who was a total spitfire, like coming in with her cane, and you know, she was saying, she's like, you know, I like this. She's like, I'm not going to use it. And she's like, oh, honey, I don't mean to hurt your feelings, but I'm not going to use this. And I'm like, it's okay, you're not hurting my feelings. And she's like, this is just too hard. And I could see it, like when she was trying to pull things up on her phone, and her hands were a little shaky, and trying to get it into the headset and get it on. And I was helping her strap it on, and I was like, ooh, this would be too hard, versus someone else who, you know, had that dexterity, and it, you know, they'd done something like this before, you know, they're like, boop, 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 put it on, and it was like good to go. A little too hard for what I was seeing with, you know, older participants. And then also timing of experience. So this was geared towards pre-treatment, but the feedback I received saying, you know what, I don't think so. It should really be more like maybe second treatment in. That would be a good time to have these stories. And I was like, well, maybe I actually need to rethink the stories then. And so then I thought, well, maybe it would be good to have like a library that people can pick, you know, based on where they're at emotionally or educationally, or, you know, where they just feel like they're ready. Because, you know, feeling ready for something, I think, is really important, which is something I did not test in this, but readiness is definitely important. But I just realized I was off with timing, like from the feedback that I got. And I was like, But it was helpful, again, to have this early feedback, so then I can go back and change things, you know, around the experiences. And then, you know, for the successes and challenges, you know, very happy that I was able to apply all the design thinking process, because it is very labor intensive. And then I gained a lot of experience in UX research and design. That is not the kind of work that I normally do at Christiana. And it was qualitative, which now I'd actually do a lot more qualitative work. And then, you know, I was pleased at the early findings. They support, like I was on to something, you know, like a meaningful track, promising track, but I certainly missed the mark in certain areas. I would have to go back and change it. And then, of course, you know, just completing the study, like the triple aim part of it, I was certainly pleased with. But the challenges around this kind of work, limited funding, like I have postdoc funding, I absolutely would have to get grant funding to scale it up to high fidelity, and then needing that technical expertise. You know, I take classes, or I did take classes, I mean, and I'm nowhere near like proficient at all. Just having a basic understanding is probably where I was at. And it was incredibly time consuming. But then again, you know, it was me doing the work, like because you know, I was learning and training. So, but having, like, you have to have a bigger team to divide and conquer around this kind of work. And then, you know, where I would go from here, which, I mean, I now work full time at Christiana, so I have not done any more work with this. But, you know, if there's ever an opportunity, if, you know, someone else would like to partner around it, but, you know, really incorporating these findings to improve the experience, have to do more testing. But a big thing here, and I know in academia, because, you know, going back to Pittsburgh and being in that academic environment, it's a lot like, okay, I'm going to apply for this grant, get this money, do this work, and then what's the next grant? And it's, you know, Pittsburgh is very, you know, it's research intensive. So they're always thinking about grants, and they're always looking around for grants. And it just seemed like that, you know, there was a disconnect of, you know, doing this tremendous, you know, and not saying this, but just in general, tremendous great work in academia that, you know, it's grant funded, but then it doesn't have that conduit, that bridge to get it into practice. And, but to get something into practice, of course, it has to be sustainable and scalable. And what does that look like? And it doesn't, like, it seems like the culture is different in academia, that there's less emphasis on sustainability, scalability, which is what we think about in the healthcare system. So I did notice that going back into academia. And then, you know, need funding, need technical partnerships. And, you know, it's a constant testing, evaluating. And for me, like, I think it would be a great idea to have a library. And I know there's a lot of more people. And actually, my background is I'm a CHOP nurse. I was a CHOP nurse for 20 years, so I'm pediatrics as well. And you know, I think this would be something fantastic for families, and maybe there's something for kids, and to build something, you know, special for them during a really stressful, scary time. And that's it. That's my presentation. Thanks so much for listening, and I hope you found it yeah, interesting. Thank you.